So our keynote speaker is none other than our own Dr. Shawn Robbins, who is an associate professor in the School of Physical and Occupational Therapy at McGill. He completed his bachelor's and his PhD at the University of Western Ontario. It seems you liked it so much. And he completed a postdoc. He moved to the University of Dalhousie, where he did his research. At the moment, it focuses on neuromuscular and biomechanical factors underlying mobility in patients with orthopedic health conditions, particularly in osteoarthritis. So he's examining biomechanical mechanisms that underlie knee osteoarthritis progression and the effectiveness of treatment of these patients. So he also evaluates the impact of player characteristics, task demands, and also the equipment design on ice hockey skills. So the title of his talk is Biomechanical Evaluation in Orthopedic Conditions, Evaluating Disease Progress and Treatment Outcomes. Dr. Robbins, so yours.
All right. First off, I want to thank everyone for the invitation to present here. It's always nice to kind of present to the different medical teams and students kind of around Montreal. So again, my primary appointment is in the School of Physical and Occupational Therapy. I also have an affiliation with the Perform Center, which is attached to Concordia. And I'm also affiliated with the Department of Kinesiology here at McGill. And finally, my research lab's actually in the Lethbridge Leighton Mackay Rehab Center. It's down in NDG, but I have some space on campus as well too. Just before I get started, I just want to acknowledge kind of some of the collaborators, including some of the surgeons at the Jewish General Hospital. I also have a lot of students and lab personnel that I work with, and then there's just various sources of funding. So getting the poll coming up. So I'm going to cover kind of what is biomechanics. I know this is kind of a simple start. I'm sure some of you have taken undergrad biomechanics or introduction to biomechanics courses, but I'm not sure if that's a component of the medical program. So we'll just go a couple slides of just defining what it is to start. So just moving things around here because I got too much going on my screen. Here we go. So kind of a simple definition of what biomechanics is it's a science that studies the influence of forces on the living body. That's a pretty general definition. The one I kind of use with my friends a little bit more is the interdiscipline, which describes, analyzes, and assesses human movement. So that definition is pretty specific and implies we're looking at humans, which is not always the case. There's biomechanics animals. But there's also some biomechanics at the tissue level as well too. But you know, when I'm talking to my friends who aren't involved in academia, I kind of summarize it as I use math and physics to analyze motion in either patient populations or sports settings. And that's kind of the area that I focus in, but it's a little bit maybe too specific of a definition. Kind of the more general definition is the application of mechanics to biological problems. So that incorporates both looking at general movement at the joint or human level, but also looking at kind of tissue mechanics. It obviously crosses a lot of different fields, math, physics, engineering. We all use those principles. We work often biomechanics is done in the engineering department as well in different health-related departments. Obviously biology, chemistry, physiology, and you see it again in health sciences and medicine. Kind of where it's used are the areas of research. Sports is kind of one of the big ones. I have two streams of research. I do work in the sports field, and you'll see a little bit at the beginning of the presentation. You know, analyzing sport movement, looking at ways to improve performance, for instance, testing equipment. Another big area that you guys may be familiar with is in ergonomics and design. So, you know, designing better workplace stations. You know, a lot of the initial work in biomechanics was done in factories where people were going in there and looking at lifting and loading tasks and finding better ways to have people do those so they don't get injured as often. The other area that I work in is in medicine, surgery, and rehab. So we're going to look at those today for a lot. You'll see a little bit in cardiovascular, but definitely in the fields of neurology and orthopedics, there's a lot of biomechanics research out there. So I'm sure you'll probably come across some of it in your studies or when you guys are working. So again, my area is kind of measuring motion. So we're going to talk about how we do that and some of the technologies. So we're going to first kind of describe those technologies, and then the last 3/4 of the presentation is going to be looking at how we use those to kind of answer kind of clinically relevant questions that we have. So for the last 30 years, there's been different technologies. The two main ones that we'll focus on are kind of an optical motion capture system and also an electromagnetic system. The optical motion capture is kind of what you guys are familiar with. You can see here there's little balls. Let's get my pointer out. Little reflective markers, and we place those on this on the subjects or patients around anatomically relevant points. We have these cameras here, and the cameras emit an infrared light, gets reflected off the markers, and then the camera is able to pick up the position of the markers. There's other markers too that actually emit their own light at different frequencies, but most often you see what's called a passive system where these markers are just reflecting light. You guys are probably familiar with this in movies and video games where they, have actors with reflective markers on them. They'll film something and they'll layer the animation on top of it. We do something similar, but instead of laying the animation on top of it, we're just interested in the numbers. So how the different limb segments are moving. The other type of system that you see more often is the electromagnetic system. We have little sensors that are placed on, like the shank, the thigh, so different segments of the body. They emit electromagnetic pulse, and there's a receiver that's capable of picking up where the position is in three-dimensional space. Kind of the two differences here, the optical motion capture system, they're not wired, so patients are more freely to move. The problem is you have to place these reflective markers in relevant positions, and when you have students and stuff, you're trying to keep things consistent, which can be a challenge. Also, when you're done, you have to make sure that the computer has things identified correctly. So if you have a marker on the left lateral malleolus, you got to make sure that it's the left lateral malleolus and it's not reading the fifth metatarsal head. So there's a lot of post-processing and that can occur. And that furthermore, these markers can kind of be more occluded. When they walk, you may be missing certain ones because the arm's swinging by the hip, so you may be missing a greater trochanter for a couple frames. But again, it allows freedom of movement. With the electromagnetic one, they're wired, so it's better for kind of more short movements when there's more constrained. So something like a lifting task, a sit-to-stand task, where they don't have to move too much. The problem with that is any metals get in the way. So if you're looking at kind of putting these in other technologies like MRI or fluoroscopy, there's going to be obviously issues. So yeah, this is maybe not the best technology for that, but it has its uses for sure. I'll show you a typical kind of data collection. In my lab, we have kind of cameras which are kind of attached around the roof on a railing system, and we keep it there. Again, I do a lot of sport-related stuff too. So we do some stuff with ice hockey. We have a grant through Bauer and NSERC, which is one of the engineering and engineering and sciences federal funding agencies. And so we actually are testing some of their equipment, and then we also have some other questions on top of it. So we have to actually take all the cameras and bring them to the ice and test there. So I'll show you a short video of kind of a typical collection for that. It's a promotional video for the lab, so there's a bit of music there. So we have reflective markers. Often they're placed, we try to place them on the skin, but since these people are going to be skating in the ice surface, we had to put a suit around them to keep them warm. So we try to get them on the skin as often as possible, but couldn't do it in this case. So you can see the camera system is fairly extensive in terms of what we have to set up on the ice. So that's an example of kind of a quick collection there. Again, I'm showing the hockey stuff because people tend to get more excited about this. When I talk to my family about what I do and I talk about orthopedics, they don't really care. But when I talk about kind of Bauer and hockey testing, they get a little more excited. This is kind of the data we get from it. This is a different study where we looked at different shooting tasks. So the green little balls you can see in the screen, those are actually the reflective markers. And then we just laid some bone animation on top of it, although we don't use it. You can see kind of attached to different segments, there's little lines. Those are the coordinate systems. And those are what we use to kind of look at calculating joint angles. So again, taking it to the ice has its challenges. We did some stuff with soccer this year as well too. And again, we had to kind of keep moving the system around, which can be a bit of a pain. So once established in my lab, it's for the orthopedic stuff, it's pretty easy. We just calibrate the system and we're ready to go. So there's no setup. Kind of moving forward, there's kind of new technologies and stuff that's probably going to be used more in the future as well too, I think, which is going to take over. We have this markerless motion capture system now. So what this does is previously the stuff we use, it looked at, just measuring the position of reflective markers. With the markerless motion capture, it takes usual video data. So the images of the person as they're walking, like you would film with your phone. And again, we have kind of a system now that we just purchased that has 8 cameras, so we're able to get them from different angles. And what the software that we use, which is through a company, Thea Markerless, what it actually does is in the past they've taken thousands and thousands of images, and they've identified 60 or I think it's around 60 anatomic points on the body, and they've gone ahead and digitized each of those images. And then through machine learning, now when you put new data in there, new video, the computers or the software is able to kind of map the bones on the person when they walk. So now we don't have to worry about adding reflective markers to people. The collection time goes from an hour to 15 minutes. And there's we save time in post-processing where the bones are kind of just added in. So we just got this system I think in January, end of January, early February, and we set it up in March. It's for March break, and this is, it took us about a day to set up, and this is just some initial data we got from it of one of our students walking. So you can see that we don't have any reflective markers on her. It's just all video data. I mean, if we didn't have the bones there, we could see her face. And it automatically identifies the location of the bones based on, kind of the machine learning algorithms of the past. So that's kind of what we're moving towards. Again, we're using it for some of the sports stuff, and eventually, hopefully, we'll transition it to some of the orthopedic questions I have as well, too. The other one that is you guys are probably more familiar with are kind of inertial sensors. Often you hear them called wearables. And there's different types of wearable sensors. The ones most often kind of describes are something that includes like an accelerometer and a gyroscopes. So they're able to measure kind of acceleration and also kind of angular acceleration and position as well. And then we also have some, which kind of the better ones have magnetometers, which kind of give you a bit more of a position sense and help deal with drift. We have one of these systems, which we'll show in a bit. It's kind of more of a higher end system. The examples here with the little orange sensor. With these ones, we have them placed around the body for various limb segments like the shank, thigh, foot, all the way up through the trunk and the arms. So we're able to get a 3D image of the person as they're moving and get multiple joint angles. There's some simpler setups too, where if you're just interested in getting the knee angle, say after a knee replacement, you may just have one on the thigh and on the shank, and then you can get a measure of knee angle when people are walking or moving. So you can go from kind of a lower cost couple sensors to kind of more higher end whole body. It depends what your research question is. So I have a student we've kind of been using this more for our hockey stuff recently. But I have an honors student who's working on a figure skating project. So you can see here that there's no cameras on the ice. She has those initial sensors kind of on her, underneath her clothes, on a suit. And we're able to get a kind of 3D image of her when she's skating. So this is a project she's working on for her final year of bachelor's, and she's hopefully turning into a master's if we can find some funding for it. There are some limitations of the systems we haven't really talked about. We don't get a lot of good global measures in terms of how she's moving around the rink. Just can get kind of what her body's doing relative to what other segments of her body are doing. All right, now so we looked at some of the technology, we'll go over kind of quickly some of the research that we do with this. This is one study that we're looking at kind of how movement patterns relate to injury risk. This one's actually in revision right now. We submit revisions in January, so hopefully we get it accepted soon. Kind of the theme for most of the clinical talk is going to be around osteoarthritis. That's where I did a lot of my training, and I still do a lot of research in that area. So before we talk about osteoarthritis, we're talking about potential injury risk factors that can lead to osteoarthritis. So in sports, the majority of knee injuries, especially ACL injuries, are non-contact related. So what I mean by non-contact, it's when you're running and cutting or jumping, and then you rupture your ACL without contact from another player. Contact injuries, like if you're running in football and someone lands on the outside of your knee, that'd be a contact injury. But again, most ACL injuries are due to non-contact events. So you're not in contact with another player. So one of the reasons why we kind of look at motion of this is we think that kind of errors in the movement patterns or how players are actually move, like run or land from a jump, they place them at greater risk of injuries. So there's been some research done where they've actually taken video data of people who've had ACL injuries and analyze the motion of the leg. And what they see is this kind of in this image on your screen here is kind of that, what they call a dynamic valgus position in a way, where the ankle's lateral to the knee's a bit lateral to the hip. And what happens is you get this excessive knee abduction. Often the knees land it more and extend it, so less knee flexion. And there's also excessive hip internal rotation and adduction, and sometimes you'll see excessive eversion or pronation in the foot as well. Now, if you look at the rate of ACL injuries in males and females, and you adjust for kind of sport participation, females have a higher rate of injury. And one potential reason, there's probably more, but one potential reason for that is that females are more often to demonstrate these kind of negative movement patterns. So that's been an area of research looking at how males and females move differently during these kind of sport dynamic movements, like landing from a jump or running and cutting. We were interested in also how those ages, how age impacts movement patterns as well. So are younger athletes kind of more risk for these abnormal movement patterns than kind of adults? So that was our research question. We want to examine differences in joint angles between the sexes and ages during unanticipated sidestep cutting task in soccer player. So again, a sidestep cutting task is if you're running down the field, you plant with your right foot, and then you cut to your left. The image here is one of my students, Sophie. She worked on this, another project in the summer, which we're still working through the data, where we actually looked at some obstacle avoidance as well on top of it. So she's a soccer player for McGill and was a great help with this, making sure we keep it relevant to soccer. So here's an example of a collection. This was a little bit of pilot data we had from the summer. We actually had an obstacle another player was challenging, but we're not going to kind of present those results today. We're going to present kind of the study we completed about 2 years ago. So again, they're just running, and then all of a sudden they have to cut and respond to some type of stimulus. So for this study, we recruited kind of adolescents and adult soccer players who are all playing at a high level, either AA or AAA for the adolescents and university soccer players for the adults. We had both males and females. This is one of the studies that we were collecting during COVID, and then all of a sudden we had to shut it down. So we didn't get to, I think we were looking for 30, so our sample is a bit underpowered for this because of that. So to complete kind of an unanticipated cutting task, again, so they would have to start running, and they had about a 4-meter approach. There was a screen, and we want to make it so that they had to respond to a stimulus. So it wasn't just, okay, you go next time you go left. What happens is a screen, and when they got close to the cutting zone, an arrow would appear, and they'd have to cut left or right. That makes the task a little bit more demanding. And then we collected kind of the data, what we saw with kind of the 12-camera optical motion capture system. And we collected at a different location just because they had a bit more room in their lab. It's going to give you a bit of a summary of results. We found females had kind of less hip flexion range of motion. They had greater hip adduction, which we'll look at below, and greater ankle eversion. Okay, the hip adduction, ankle eversion, those would be kind of movement patterns we want to try to avoid that could place them at greater risk. When we look at the adolescents, they had greater hip internal rotation, and also they had a greater knee flexion angle. They tended to stay more flexed. They didn't have as much changes from a flexed to extended position. Again, that hip internal rotation is one of those motions we want to try to avoid when we're doing a cutting task. So here's an example of some of the data we get. On the vertical axis, we have our hip adduction angle. Positive values actually represents adduction or adduction, and negative values represents abduction or abduction. So taking the leg away from the midline. Red, we have females, and black, we have males. And then adults are in dashed lines and adolescents are in solid lines. And we have on the horizontal axis the percent cutting cycle. Well, 0 is actually about 10 milliseconds before the foot hits the ground. Then the foot hits the ground, and 100% is when the foot comes off the ground. So we're looking at that stance phase. And kind of when we do put this through some statistical analysis, I'm really not going to describe that. If you have any questions, let me know. But what we find is that overall, the females tend to have greater hip adduction. So their hip is less abducted, I should say. Okay, so they're close, bringing that leg close to the midline throughout the task. So just to kind of summarize, we found that risky movement patterns are demonstrated in both females and adolescents. Some of these could increase the risk of injury. Also, there's a few where it could diminish their performance. For instance, with the adolescents group, again, they tend to keep the knee more flexed. They don't go to a more extended position when they're pushing off, so that would kind of diminish their performance a bit. So how this is clinically useful is there's a whole host of injury prevention programs out there. One of the big ones is a FIFA 11 Plus. There's other programs out there that go to retraining mechanics or how people land from a jump. So these injury prevention programs, there's been some research, epidemiological research showing that they're effective. We're kind of more interested in the future looking at, can they actually change movement patterns? So that may be a way that these injury patterns, programs, they look at, here's typically what's wrong, and they teach coaches what's wrong when players are doing the different training drills, and they teach them kind of more correct positions as well. So again, real focus on improving movement with these injury prevention programs. So not just warming up, not getting them just warm to run and doing dynamic stretching. It's more about encouraging proper movement, and they do that throughout the season. So next study we're going to go through is, again, we kind of started with injury risk factors for traumatic injuries. 40% of people after they have a knee trauma develop knee osteoarthritis, 10, 15 years down the road. So now we're going to look down the road and look at kind of disease progression. So once people have kind of the disease of osteoarthritis, factors that kind of make the disease worse or make it more severe. So this one, the work we published in osteoarthritis cartilage in 2021. All right. So knee osteoarthritis kind of overall is often seen, again, it simplifies a bit, but it's often seen as a disease of loading. So one of the biggest risk factors for knee osteoarthritis is body mass. So heavier body mass means more load in the knee, and that is one of the reasons why people develop knee osteoarthritis. We have certain metrics that we take during gait, and one is what's called the knee adduction moment. And this is kind of a simple representation. The image there is that when you walk, you're hitting the ground, and the ground hits back to you. So there's an equal and opposite force that goes back through your limbs. And that ground reaction force passes medial to the knee. So what does that creates a adduction moment or a torque about the knee. That's pulling that shank inwards relative to the femur. And what we found is that knee adduction moment actually predicts the progression of the disease, especially medial compartment knee osteoarthritis. So if you have early or mild signs of medial knee compartment osteoarthritis, and you have a high knee adduction moment, that medial compartment is going to become more severe than if someone has a lower knee adduction moment, or your risk is greater for developing more severe forms of the disease. And that knee adduction moment, what it is it really looks at a proxy of the amount of loading from the medial to lateral compartment. So if you have a higher knee adduction moment, your more of your load is shifted to the medial compartment. And if you have a lower knee adduction moment, more load is shifted to the lateral compartment. So it gets at that loading distribution within the knee. Kind of question I had during my PhD, which I started working on then and a little bit of my postdoc, but it's been kind of focus of my early career, was looking at subtypes of knee osteoarthritis. We have these two subtypes. We can talk about them being non-traumatic or post-traumatic. Post-traumatic would be someone that maybe sustained an ACL injury, and then in 10, 15 years down the road, they developed knee osteoarthritis. A non-traumatic would be someone who developed knee osteoarthritis without a previous traumatic injury. And although most of the work has been really focused on non-traumatic samples of people with knee OA, clean medial compartment, medial compartment knee OA with little lateral compartment involvement. But we were kind of interested in looking at, are the factors for disease progression, do they vary between these two groups? We do see kind of on X-rays and MRIs, there's kind of differences of disease markers between the OA types. So non-traumatic people, they're more often have most of their radiographic changes will be in the medial compartment, while people with post-traumatic who have a history of injury, their radiographic changes related to knee osteoarthritis would be more evenly distributed. So both in the medial and lateral compartment. So if we see kind of markers of disease progress being different between these two groups, we're wondering if risk factors for progression vary as well. So the purpose of this study was to determine if knee moments, specifically knee adduction moment during gait, were associated with knee OA progression over 2 years, and to examine if this relationship varies between non-traumatic and post-traumatic knee OA. Now we're going to focus on the knee moments. We also looked at other kind of functions of the muscle and joint angles as well, but we'll just go to focus on kind of the knee adduction moment today. So we had patients with non-traumatic and post-traumatic. That was our ending of our sample. I think we recruited 21, but we lost a few to follow-up. They went through our lab, and this is just kind of an image in the lab where we have the reflective markers on the people. We have cameras around the ceiling. And then that was our motion capture data. We also have force plates in the ground to let us measure that ground reaction force. And as well, as we'll talk about later on, we had electromyography. So kind of what we get out of that are the knee angles, our external knee moments, including our knee adduction moment, and our muscle activation as well too, which we're going to kind of skip for this part of the talk. For a measure of disease progression, we used MRI imaging at the Perform Center in Concordia. And we had people go under MRI at 0 at the start of the study, and then also 2 years down the road. We partnered with some researchers at UDM who had a private company called ArthroLab, and they were able to take the MRI images and able to kind of outline the amount of cartilage there, or the cartilage, and then get a measure of cartilage volume or cartilage thickness. So a measure of disease progression was actually the amount of cartilage in both the medial and lateral condyles of the femur, and also the medial and lateral plateaus of the tibia as well. Here's an example of kind of a typical knee adduction moment. These are our 3 groups here. On our vertical axis, we have our knee adduction moment. Again, higher values represents they're kind of shifting the load to the medial compartment, and lower values means they're shifting more of the load to the lateral compartment. And this is over % of gait cycle, where 0 represents heel strike, and then 0 to 60, you're standing on your leg, and then 60 to 100, you're swinging your leg. So we had the 3 groups. We actually also had a healthy group just for the baseline gait assessments. So overall, the knee adduction movements are fairly similar between the non-traumatic, post-traumatic knee OA groups, and also the healthy group as well too. Here's a scatter plot. Here we looked at change in the cartilage volume for the lateral condyle. Negative values means they lost cartilage. Positive values means they kind of gained cartilage volume. Again, sometimes the gain cartilage volume could be because of just increased water, so there's a bit of swelling in there as well too. That's part of the early knee osteoarthritis process. Predominantly, people lost cartilage. On the horizontal axis, we have our knee adduction moment, where again, higher values means they're shifting load to the medial compartment. Lower values means they're shifting load to the lateral compartment. We have our non-traumatic and post-traumatic groups. So again, what we see here is that people had lower knee adduction moments. They tended to lose more cartilage in the lateral compartment, which was consistent. And they're actually similar between the 2 groups. We were expecting potentially interaction, but we didn't see that. So those are kind of common findings in the lateral compartment, both in the condyle and the tibial plateau. We actually didn't find any relationship to the medial compartment measures which is kind of different from previous studies. Lower values on the, again, just to summarize, lower values in the knee adduction moment relate to increase in lateral compartment cartilage loss. We had other variables. Actually, there was a bit of an interaction where for the non-traumatic, these certain variables would be related to cartilage loss, but it wouldn't be in the post-traumatic group. So some of the risk factors, potential risk factors, did vary between the two groups. Again, some of the results agreed with other studies, some didn't. Our sample, again, had a post-traumatic group which hadn't really been investigated before. We also had, instead of taking kind of a clean medial compartment group, we took people that had kind of equal distribution or even had more lateral knee OA. Because we were interested, because in people with post-traumatic, they tended to have more of a lateral compartment OA as often as medial compartment. So our sample was a bit more heterogeneous than previous studies. Kind of the findings have impact on management. Again, a lot of the surgical options or even kind of rehabilitation options look at changing load. So for instance, a high tibial osteotomy is where they actually change the alignment of the tibia. And what you're basically doing with the high tibial osteotomy more often than not is shifting the load from the medial to lateral compartment. And that may be good for people with non-traumatic medial compartment OA, but it may be less so for people with post-traumatic knee OA. Similar, there's some bracings that do try to do the same thing. And again, it may be working from one subgroup versus not the other. Again, in the research as well, too, I think these groups are not with the data that I showed, but with some of the other data that was in the study. There are some differences in how they on some of their gait metrics when they walk, like EMG, and there's the response to kind of disease progression varies. So, in summary, when we're looking at these groups and how they respond to treatment, and our research of those treatments, I think we need to look at these two groups separately and at least do a sub-analysis of them as well. So now we talked about the disease, we're going to go on to kind of end stage treatment of the disease. We have an ongoing grant now that's funded through the Arthritis Society. So we're going to present some preliminary data from that. And it's going to be focused around knee arthroplasty or knee replacement. There's over 67,000 knee replacements in Canada done annually. The number's a bit higher now. I think we're up to more over 70,000 now that the pandemic's over. And although the surgery, most people do well after surgery, there's still about 20% of people that report unfavorable outcomes, either kind of long-term pain or they're just not satisfied with the surgery. There's different research kind of areas looking at why these 20% of people are happy. One of the ones that look at it is, can we design knee replacement implants to kind of more better replicate normal knee motion? So when you do something like a squat and you're flexing your knee, what happens is the medial compartment, it tends to act more of a pivot. There's less translation there. It tends to pivot more. Where a lot of that translation that naturally occurs, again, we're only talking about millimeters movement, but it occurs more in the lateral compartment. So more translation in the lateral compartment and more of a pivoting action in the medial compartment. And that's kind of normal knee movement. So some of the industries, some of the TKA companies that design these implants are trying to more replicate normal knee motion. The thought is if we can replicate more normal knee motion, that's going to maybe bring down those 20% of people that aren't happy with it. So one of those implant designs that we've seen is called the medial pivot implant. Most companies have some sort of medial pivot implant. Usually they make the medial compartment a bit more congruent and a bit more round, and so you get more pivoting action there. And then it allows kind of more translation in the lateral compartment. So some of this research has looked at, putting these medial pivot implants in people, and then they look at, maybe 6-7 people under fluoroscopy, and they look at kind of a constrained movement. So they may have the person squat from 0 to 45. They look at how much translation's there. And generally find with the medial pivot implant, you're getting a little bit more translation within the joint as expected. But we really haven't looked at kind of larger samples and looked at more dynamic functional movements like walking, like stair climbing. Again, with fluoroscopy, it's hard to kind of get that motion because you're constrained to be within the field of view of the fluoroscope. So that's what we're interested in, is using kind of our motion capture expertise to compare knee mechanics between patients following TKA, either had a medial pivot or more of a traditional implant. And we looked at walking or gait and a kind of a step up down tasks. We're collecting at 1 and 2 years post-op as well as pre-op, and right now we're just going to present some 1-year data. Again, we're just part way through this, so we're still collecting. So right now, for the data that's available for us for 1 year, we have 7 and 6. Now, the 2 implant, 7 people in one group and 6 in the other. We're hoping to get, I think, 48 in each group. The 2 implants we're looking at are the Zimmer medial pivot persona, which again is a medial pivot type, which is supposed to replicate more normal human motion. And then we also have kind of more traditional implant design, which is Zimmer persona knee PS design. Now, I'm the person that's blinded to group allocation. So although I got 0s and 1s in terms of what groups they are, I don't know what implant that implies to. So I can't tell you which implant is performing better so far. All I can say is group 0 and 1. The surgeons obviously know what implants are going in the person. So once I finish the final analysis, I'll be unblinded. We looked at, again, pre-op 1 and 2 years post TKA, and all the surgeries will be done in the Jewish General Hospital. We just added the Montreal General Hospital as a site as well too. So patients come into my lab, they do a kind of a walking task, as up to 5 trials, actually a few more. We keep a couple extra just in case. And they also have a step up down task. And we look at kind of motion capture from that, force plates, and also EMG, which we'll talk about a little bit later on. Kind of our primary outcomes for this is we're looking at, can it restore normal knee motion? The ones that we're most interested in are knee flexion range of motion and also internal rotation range of motion within the knee during these different tasks. So here again are the kind of a gait curve showing kind of the person throughout gait. On the vertical axis now we have the knee flexion angle, where higher values means they're flexing the knee more. 0 is they're extended. And then we have percent gait cycle, where again, 0 is when they're hitting the ground, 0 to 60 they're standing on that leg, and from about 60 to 100 they're swinging that leg. We have the group 0, again, I'm blinded, so I'm not sure what group 0 means. We have them in black at pre, which is dash, and at 1 year, which is solid. And then we also have the group 1 in red. Again, both the pre and the 1 year scores. For the sake of this presentation, we're going to just look at kind of range of motion in the stance phase. So we're looking at what their most extended position in the stance phase is and what their most flex position is. And we're taking that as a range of motion measure. We submitted this to CSB as an abstract, just showing some preliminary data. That's the Canadian, COA, Canadian Orthopaedic Association meeting coming up. We tend to do more sophisticated analysis of these variables, but just for the sake of this and because it's a kind of just partial analysis, we're just going to look at range of motion. So just going to pull some numbers out of those curves for you. This is the data at 1 year post TKA, and it's for the gait. It's a similar finding for step up as well. These are 1 year data, but they're adjusted for the baseline scores. So we're running an ANCOVA in this, where we look at the 1 year data, again, adjusted for the baseline pre-op scores. We have flexion range of motion and internal rotation range of motion are 2 variables. What we did find is that the flexion range of motion was higher in group 0 versus group 1. Again, it's a small sample, so it's just a partial analysis of results. Can't make too many conclusions, but we didn't really find any differences in internal rotation range of motion for now. Although it's about a 2-degree difference, just not statistically significant with our small sample. So preliminary results so far, so we can't make too many conclusions. Group 0, they had greater range of motion during gait and during a step up task. There was no difference between the groups in the step down, but we're still collecting, so we can't make too many conclusions so far. All right, we're going to get away from motion for a little bit. In the last, 10 minutes of this talk, we're going to talk about measuring muscles. So we talked about how to measure motion, but muscles, they're complex things to measure, and they're not easy to do. We can't really get any direct measures of force within the muscle, which would be nice to allow us to kind of look at a lot more variables around the joint, like the amount of direct loading force, which we can't necessarily get. So as I'm sure all you're familiar with, when you contract a muscle, there's electrical current which flows in the muscle, and we're able to pick that up. using electromyography or EMG. So that gives us an idea if a muscle is turning on and when it's turning off, but we can't get a direct measure of that force within the muscle. We just know there's electrical activity, but we can't directly relate to force for numerous factors. So that would give us an idea to measure, muscle activity when people are doing kind of a functional task, again, like walking and jumping or running. We're also able to measure kind of just muscle strength, traditional muscle strength, either isometric strength or isokinetic strength using this isokinetic dynamometer. You can look at concentric strength and eccentric strength, but again, they're not really done in a functional way. You just have someone sitting there. If you're looking at knee extension strength and you have them push them against a bar or a pad, similar to what you would in the gym. But we're able to get kind of measures throughout different strengths, and we're able to change the speed of the contractions. And again, it gives us a nice measure of muscle strength, but not always the most functional measure. So we're going to look at kind of how we use some of this data for evaluated treatments. This is a study we published a few years ago. We're looking at how muscle activation and joint mechanics change based on the type of type of hip arthroplasty approach you had. So when you receive a hip arthroplasty, the two most common types of treatments are kind of posterior and lateral. The anterior approach is making a little bit more of a gain now. And the posterior and lateral approach are the ones that are done at the Jewish General Hospital. So we're interested in those. With the posterior approach, when you're going there to access the hip joint, you come from posterior direction, you go disrupt kind of the gluteus maximus and the short lateral rotators and the piriformis. Well, from when you're coming from the lateral approach to access the hip, you go disrupt the gluteus medius and minimus. So we're interested in kind of how those surgical approaches impact muscle function long term. If you're disrupting this muscle, does it regain strength, and is it functioning normal during functional activities? So our primary objective was to compare muscle activation during gait between patients that had a lateral or posterior approaches for total hip arthroplasty. We looked at 1 year post-surgery. We also compared them to healthy adults. And we're also interested in comparing isometric strength on the dynamometer. So we had patients come in the lab, 21 from each group. Again, we put them through a gait assessment of a kind of described before with the motion capture system, force plates, and also the EMG this time. And we're able to kind of get measures of muscle activation when they're walking. In addition, we're interested in gaining some strength values. We used isometric tests of some of the hip muscles. The reason we use isometric strength testing is because we often compare those gait or walking EMG measures to some standardized contraction. And very often it's a voluntary isometric contraction. So we use the data from the dynamometer to get strength, torque values, but also we use it to kind of normalize the EMG from walking. So those are kind of the two reasons why we use isometric strength. So time from surgery was about 1 year. Actually, on average is about 13 months. So a little bit after 1 year for both these groups. So here's some EMG data. On the vertical axis, we have the gluteus medius activation. And again, that's the activation during gait, but we divide it by the activation from the MVIC. So it's a percent MVIC. So higher values means they're activating the muscle more motor units are being activated, and lower values means less motor units are being activated. Again, we have percent gait cycle, where 0 to 60 represents when they're staying on that leg, and 60 to 100 represents when they're swinging that leg. We have our lateral THA group, our posterior THA group, and our healthy group here. So what we see from the graph is that overall, the lateral THA group, we put through some statistical analysis, they have increased activation of the gluteus medius muscle. That doesn't mean they're stronger. What it means is they're probably activating more motor units because they're weaker. So more activation of the muscle because the muscle fibers aren't as strong. That's kind of our hypothesis of why we get these findings. Again, we also looked at isometric strength. Here we have hip abduction, hip extension, and hip flexion. We have the values for different groups. They're normalized by torque divided by body mass, just to normalize it for differences in size. The one that we see a difference is that the lateral group, the people that had the lateral approach, total hip arthroplasty, they had the weakest hip abductors. So glute medius and So we see that they're a bit weaker than the both the posterior approach group and then also the healthy group as well too. So just a bit of a discussion and a summary of some of the results too. In the lateral THA group, like I said, they had increase in gluteus medius activation during gait, and they also had hip abductor weakness, as we see from the isometric testing. We have the posterior THA group, and I didn't show these results, but they actually had an increase in gluteus medius, or sorry, gluteus maximus activation, and also the hamstring activation during gait. And similar, like the lateral group, they're disrupting gluteus maximus activation. So this probably represents that the muscle fibers, we need more of them to contract to get the required force required for gait. What we see is that, again, these people about 1 year surgery. So we're seeing kind of these although they may not have any, intrandelbar gait anymore, they may not be showing any obvious signs of a limp. There's still some deficits at 1 year that we can address with strengthening programs. All right, so I'm just going to leave you with kind of a few take-home messages here. Biomechanics, the nice thing is it can provide objective measures of motion, forces, or muscle function. As healthcare professionals, we're not good at evaluating kind of dynamic movements like walking or running with just our eyes. People just don't agree. If you have a checklist and you're trying to rate different metrics from running, we're not good with just absorbing with our eyes. So biomechanics provides more objective measures from that. Now, using biomechanics in kind of to evaluate orthopedic populations or neurology populations, they may fit some research questions, and they can be used in conjunction with, patient-reported outcomes, surgical outcomes, typically something like implant positioning or adverse events. So, they may fit your research question, these biomechanical variables, they may not. So if your question is looking around movement and how, orthopedic treatments can impact movement, then biomechanics is a good, biomechanical variables are a good thing to measure. But again, they may not quite fit your research question. So I didn't report any of this here, but often we're collecting these in conjunction with kind of patient reported outcomes or adverse events. All right, so I want to thank you guys for the invitation and for listening. It was a bit long, and just let me know if you have any questions.
Thank you very much, Shawn, for that really wonderful presentation. Very clinically relevant. Please feel free to unmute, write in the chat, or just ask away. I think we have a question from MG.
Yeah, I'll just read the question. I saw on your KM graph that there was a difference of about 0.1 between groups. I was wondering if there is research that indicates what a difference is clinical meaningful in the patient. What is a meaningful clinical difference in KM for a patient that had treatment? There is definitely research that looks at those metrics. I'm blanking on the actual value right now, but yeah, there's been some. There's a group out of University of Western where I did my training. They've looked at this a little bit more. And I've done some research on it as well too. So yeah, there are some values to kind of look at meaningful clinical important difference. So you can find those out there. With the groups that we had, when we put it through the statistical analysis, we didn't find that there was any statistical difference between the two groups. Yeah, you did see it in the graph, but we didn't find that statistically. Again, our sample is a little bit kind of messier than other people, and that was by design. Other people, if you're taking the typical person that goes for a high tibial osteotomy, usually has predominantly medial compartment. They usually have a lot of varus angulation in their knee, so really bow-legged, and they'll have much higher knee adduction moments than what we had. We took kind of a sample that, because we were looking at post-traumatic, we didn't have to have that varus angulation that is usually seen in other studies. So if you look at some of the research, their values are going to be a lot higher than ours, but there's definitely some data out there in terms of minimal detectable change on the knee adduction moment, especially the peak. So you can look at that. I'm just blanking on the values right now.
Thank you. Any other questions? So those markerless motion capture, they seem quite very comfortable compared to putting all the markers around. So your data, which you're generating, was it mostly using the markerless or with the marker?
Yeah, the stuff we had was markered. reflective markers. When I bought the system 10 years ago, the motionless marker capture system weren't, but there was one company that was available. It wasn't used widely. So we have a markered system. The markerless one we just bought, the new one, the high-tech one with the video data without the markers. We just kind of got that up and running a few weeks ago. It'd be nice to use that for all our stuff going forward, but with the knee arthroplasty study, we already have, a lot of data collected with the markered system, so we still have to use that older system. There's been some research that it's been done in Queens where they compared actually a similar system that I have to both the traditional markered system and the markerless. And overall for gait, the results are fairly close. Flexion and sagittal and frontal plane angles like flexion, abduction, they match up pretty good. There's some issues a little bit with the transverse angles, but we're not sure if the error is coming from the traditional system or kind of the new markerless system. So overall, there's good agreement between kind of the new technologies and the old technologies. So groups out of Queens led by Kevin DeLuzio, they have some research on that. So they validated the stuff for walking. We're looking at kind of validating that markerless system for kind of more dynamic movements in sports and running. That's kind of going to be our next stage.
Well, that's really nice. Have you looked at? I know that you, for the orthopedic conditions, you're mostly focusing on osteoarthritis, and also after to look at the outcomes. Have you looked at rheumatoid arthritis?
No, we haven't per se. We've looked at other conditions like we've done some work with Ehlers-Danlos syndrome, where it's a connective tissue disorder where they have a lot of hypermobility in their joints. So we've done work with them. The rheumatoid arthritis, I'm sure there's some research behind it. I haven't really looked as much, but I don't think the metrics necessarily fit the question there as well, because they just, it's not maybe a measure of disease it's not necessarily a measure of loading per se with knee osteoarthritis. It's just the destruction because of the inflammatory processes. So I don't think it would fit the questions as well, although there may be some questions I'm not aware of that biomechanics will work well with that group. But it's used a lot in osteoarthritis because, we can get measures of loading or proxies for loading in the knee, and that's why biomechanics fits well with osteoarthritis.
Okay. Any other questions, Mike?
Yeah, sure. Great talk, Shawn. It's very interesting, actually. Had me thinking a little bit. I really like the data, how you collect it is quite impressive. I haven't seen all that technology, so it's kind of new. But just a question, like regarding the gait. So when you're comparing normal versus osteoarthritic, like patients, knee patients, is when you're measuring differences, is it always the case where it's a gait that's inducing the OA, or maybe the OA that caused changes in the gait? Like, how do you know? It's kind of the chicken before the egg.
Yeah, it's both probably. It's hard to tease that out sometimes. We think, things like alignment. We know that, say, there's been a ton of epidemiological studies that looked at, say, genu varus, predicts the development and progression of knee osteoarthritis, medial compartment knee osteoarthritis, and genu valgus predicts both the development and progression of lateral compartment knee osteoarthritis. So our measures, they're heavily influenced the knee adduction moment. If you have genu varus, traditionally that increases your knee adduction moment. So we have some kind of evidence that, it's the way people are, and it's not just the way they are that kind of leads to development of knee osteoarthritis. Now, it's not just the walking, it's the stair climbing, the squatting, the lifting. But with that said, through all those tasks, they have that same alignment. They have the deduction moments that where the loads could be shifted more either to the medial or lateral compartment. So I think that's what kind of leads to the disease. Now, what you said, what I mean from looking at the other perspective is when they get the diseases, what happens is now they change the way they walk. They may change the way they walk, which could actually impact that knee adduction moment and make things worse too. You see, as the disease gets worse, you get this varus thrust sometimes where if you watch people, their knee will start jetting out to the side, it looks like a lateral thrust. And that's been shown to relate to progression of the disease as well too. So it's both, the way they are, I think, dictates the development of the disease. Then once they get the disease, they go to change how they walk, which can make some of those metrics worse, which could further impact the disease. So yeah, it's kind of both, but I think the initial studies is kind of the initial start of the disease is, you know, how they're aligned and how they use alignment when they walk.
Perfect. And for the non-favorable, or the 20% of those who will get knee surgery, and you mentioned, yeah, there is a significant amount, right, that are non-favorable with the operation. So how is there any way to like condition them based on like managing the gait? Is there any way to either convince them to walk a different way or condition them to walk a different way to prove that?
Sorry, I may miss a little bit of the first part. You're talking about those people that have a traumatic injury and trying to prevent the development.
Oh no, now I'm talking about the people who get the surgery, who like the 20% who are just non-favorable, the ones who get it. And yeah, so is there any way they can like affect their gait so based on this?
Yeah, I think we don't have, to be honest, we don't have a good idea why these 20% are unhappy. Some of the research has shown in the past in some studies that the people that tend to be more happy are those people that are actually higher level to start with, or younger patients. So maybe they have higher expectations. So part of it could be managing expectations. There's research looking around, you know, after, you know, you cut that knee out, those peripheral pain mechanisms should be gone, right? But these people still have pain. So maybe there's some central source of pain, some change in the brain or the nerves within the central system that, you know, has changed. That's another thought of research.
Mm-hmm.
Some of it may be, again, what some of the TKA companies think, that they, you know, if they improve implant designs, people are going to be happier. So I think we don't always have a good idea. It's probably like everything in life, probably multifactorial, and, you know, we'll have to address it with different ways for different people. So yeah, it's not a simple question.
Thanks.
So there's just one question in the chat I have. Have you looked at the difference between KM and musculoskeletal models for OA? I'm not sure. I think what you're asking is if, you know, there's different ways to calculate the knee adduction moment. And there's some research out there that's showing, depending on how you calculate it, you could get a slightly different answer. So we kind of calculate it in a more standard way, which is recommended by the International Society for Biomechanics. And we put a big emphasis on how we report, how we do the calculations. I'm, you know, obviously I review a lot of academic papers for journals, and, you know, it's one of always my big pet peeves is when they don't describe how they make their model. So Marianne, I think that's what you're asking. So yeah, how you calculate the knee adduction moment can actually impact kind of the shape and look of it. And there's been some research done in the past on that. Marianne, if I didn't answer your question, speak up, because I'm not quite sure if that's what you meant.
Yeah. So a couple of years ago, I was invited to give a talk at the University of Alberta, and they took me to this lab, which was a sport lab, mechanical lab, and they were trying to look at the mechanics of running and jumping, and how footwear and training programs, how they affect performance and injury risk. But one of the things they were also talking about was the use of this wearable technology that we were trying to develop to monitor movement and muscle activity. Because you talked about muscle and how, so is there any of those wearable technology that can be used here in terms?
Yeah, definitely. I think one of the things we do is, you know, we bring people in the lab and we get them to walk 5 times, right? Well, a lot more than that. There's a climatization where they have the equipment on. We get them to practice a bit. They're usually walking a bit slower, more hesitant. And then we get them to walk kind of, as they get more used to it, they walk normal. But they're still in a very artificial setting, right? And, you know, obviously when you guys are out there walking day to day, you know, maybe you're walking your dog and you're going for a slightly, you know, slower stroll. Then you're walking fast to catch a bus. So the nice thing about the wearables is they would be able to capture those things throughout the day. You know, right now in the lab, you know, we get a snapshot and not a full video of what people are like. So the nice thing with the wearables is you'll be able to get more data of what people are doing throughout the day. Now, we're not doing a ton of research, our group right now with that, but it's definitely an interesting thing to keep my eye on. Because if we can get gait metrics throughout the day, we get a better idea of what they're doing throughout the day, and not just, you know, when they come into our lab. And you know, with these measures, you know, our measures, our snapshots, they provide a lot of clinical useful information, and they relate to measures of progression. But if you know someone's walking 5,000 steps a day versus someone who's walking 15,000 steps a day at different speeds, you know, that impacts kind of the load throughout the knee as well too. And that's the piece we're missing as well. I did some work in my PhD trying to measure kind of more cumulative measures of load, looking at daily load, but it's a hard thing to capture.
Okay, thank you very much. There are no more questions. I would like to thank everyone for coming to the wonderful seminar. Thank Shawn for this really clinically relevant research, not just putting test tubes on the bed.
Yeah, thank you very much.
That stuff is interesting too. That always blows my mind. So, you know, gels to help healing. I think that's incredible. It makes me think of sci-fi stuff, right? So that's amazing.
Yeah. So thank you very much, Shawn, and thank you, everyone. Have a wonderful week.
Thanks, Shawn. Bye.